We're very pleased to welcome Tara Resnick and Lindsay Stacy. Both are psychogeriatric resource consultants with the RGP of Toronto and the Psychogeriatric Resource Consultation Program of Toronto. A very brief introduction to both of them. Tara is a geriatric social worker by background and brings extensive knowledge and experience in long-term care, where she led the responsive behavior program. Lindsay has a background in health and aging and brings to the PRC team many years of experience and knowledge in geriatrics from acute care as a behavior consultant, case management, and also transitional support. Before we begin, I'd like to let you know how to engage with our presenters today. Please type any questions or comments that you have in the chat box at any time. We will start our question period after the presentation has concluded, and we will be answering your questions then. I will answer the most commonly asked question: can we get a copy of the slides and recording for this webinar? The answer is absolutely you can. We will be posting the webinar on the RGP YouTube channel, and we will be sending a copy of the slides to the attendees and also post the slides on the website as well. And with that, I'd like to invite Tara and Lindsay to take the stage.
Thank you, Mario. I'm just going to turn my video off because I get really distracted. So we'll see you at Q&A. All right, so welcome everyone to our sixth webinar in this series. Today we're actually going to be talking about preventing and de-escalating responsive behaviors. So before we get started, we want to thank all of you on this call today who have been working in long-term care over these past 4 months, who have been supporting the staff and residents during such a difficult time. And whether you've been working in long-term care for some time now, or if you've been recently redeployed, we want you to know that the work you are doing to protect and care for some of our most vulnerable in our communities does not go unnoticed. So thank you so much from the bottom of our hearts. So some quick housekeeping items to note during the next hour that we have together today. So these PowerPoint slides will be shared with you shortly after our session today. So feel free to sit back and listen, and don't worry about having to take notes of everything on the slides because we will be sending them to you. We will be posting a recording of this webinar on the Regional Geriatric Program of Toronto YouTube channel as well. So feel free to share this link with anyone that you know who you think would benefit from it. And during the course of the webinar, if you have any questions at all related to the content, please type them in the chat box. And at the end of our session, we are going to have some time for Q&A, and we'll be able to answer your questions then. And also, we recognize that there might be some case-specific examples that require resolution, but unfortunately, we will not be able to address these cases due to time. But we encourage you to connect with your behavioral supports in the long-term care facility you're working in, as well as any external supports. And then finally, we will not be covering any de-escalation strategies for physical violence, so things like breakaway techniques or physical restraints, as this requires a specialized training beyond what we're able to provide today and really should not be attempted without this training. So for our goals for today, we are going to be providing you with an understanding of the different stages of behavioral escalation. And we're going to be looking at a chart that will give you a really good visual representation of that. We're going to help you to identify some of the warning signs of behavioral escalation, so some of those key things that you want to be watching out for. Third, we're going to provide you with some strategies for preventing behavioral escalation. And then finally, should a behavior occur, we are going to provide you some strategies that will help you de-escalate a person in that kind of situation. All right, so we want to get to know you and find out who our audience is. So we're going to launch a few poll questions. You'll see them in just a second. So what is your role? if you see any of those on there that don't apply to you, just put other. And then we do encourage you to write in the chat box, if you could, just what profession you are in. All right, so it looks like we have about 14% personal support workers, 14% nurses, 7% are occupational therapists, we have 7% PRCs, 14% admin, and then we have 43% who are others. So I mean, I'm curious to see what the others are. So I'm just gonna look up here real quick. So we have BSO, knowledge to practice specialist, the speech language pathologist, risk manager, nurse educator. That's awesome. Thanks guys for participating. And have you worked or supported older adults with dementia before? Okay, so we have 93% who have said yes, which is amazing, and 7% have said no. So if yes, we're great. We hope that this information we present today will really build upon what you already know and provide you with some new tools to use in your work. And if no, that is okay as well. We're really excited to have you here with us today, and we're glad that you're taking the time to learn about dementia in order to better support those that you're working with. And then the next question, how many years of experience do you have working in the field? Right. So about 33% have 11 to 15 years experience, 17% have 16 to 20, and over half of you have more than 21 years experience. So it is evident that there's lots of experience in the room, or virtual room, which is great. So please feel free to share your ideas, your thoughts, and even some of the strategies that you use in your work in the chat box throughout this webinar so that we can all learn from your knowledge. We would really love to hear from you. And for those of you on this webinar with a little bit less experience, I'm really confident that you also have great tips and tricks, so please share as well. And then our last question, so have you attended previous webinars in this series? All right, so 43% have attended a previous webinar and 57% have not. So for those of you who have seen our previous webinars, welcome back. And for any of you who have not attended any of the previous webinars, you can view them on our Regional Geriatric Program YouTube channel. So I'm gonna actually post that in the link just in a bit, post the link to the chat box. The other webinars we did are on wandering, things like communication, personal care, feeding and medication administration. So really helpful webinars that you might want to watch as well. So I'll make sure to post the link for you in the chat box. Thank you for participating in our poll. All right, so we're going to get started here. So all behavior has meaning. So this is a slide that we have added to our previous webinars as well. So if you did join a past webinar, this slide might look familiar to you. And this message is really just so important that we wanted to re-emphasize it because it really guides our understanding of the experience of the person with responsive behaviors. And it helps us to take a step back and really evaluate what is going on and forces us to try to find the reason for the behavior. So in dementia care, behaviors are viewed as responses to unmet needs. But what we find is that people living with dementia are sometimes labeled by their behavior. So, we might hear things like aggressive, inappropriate, combative, agitated, hoarder. So, for example, in care situations, you might find a resident is, grabbing onto something or someone out of fear, but then they're getting labeled as resistive to care or non-compliant, right? You've probably heard your colleagues say these terms before, or maybe even you yourself have even labeled someone in this way. But it's really important to note that these labels can actually be judgmental and really prevent the carers from seeking the meaning behind the behavior. And they also give us these preconceived notions about the person, which actually affects how we initially interact with the person. So, for example, I'm just going to run through an example. So, in one of the retirement homes that I used to work at, sorry, not work at, but support, the staff would frequently tell me about a resident that they were having difficulties with in trying to get her to accept help and take baths. And, she just would never even let them in her room. And I remember asking the staff what they had already tried, and one staff member said, well, she's just difficult. Nothing's going to work. And I think we hear that a lot. And so the staff had already labeled this woman as difficult and non-compliant. So before they even got to her door to offer that assistance and get her ready for the day, they had this negative label attached to her. They're almost setting themselves up for failure, if you will. So if they go into their room with this mindset, their body language, their tone of voice, the way they interact with this woman, those things are all going to be negative, and they're going to reinforce that response from her. And also, by having these labels, the staff are way more less likely to try to understand why she doesn't want their help, and less likely to figure out what is causing her to decline that support every time, because they label her as this is just the way she is. So we really need to move away from judging the person exhibiting the behavior to instead understanding that their actions do have purpose and meaning. And oftentimes it is, it's up to us to really try to figure out what it is that is causing that behavior in the first place. And we need to recognize and value that the person with dementia has the ability to express their experience, but it's often done through those responsive behaviors, especially for those who can no longer communicate. And a large percentage of those with dementia living in long-term care will have some form of responsive behavior. And it's known that many residents who come into long-term care with significant complex health challenges and multiple chronic conditions on top of their cognitive impairment. So because of that, that can really have a profound impact on their functioning. And as this disease progresses, they often lose their ability to interpret their environment or control their behavior, which is why so many individuals with dementia are going to exhibit some form of responsive behavior. And what this means for us is that as care providers, we need to have a really good understanding of the disease and also have some strategies to support them. And we often refer to this as a behavioral support, in which this is derived from over 20 years of evidence-based research and really highlights that behaviors occur due to the changes in the brain and the effect on specific brain structures. The person living with dementia often can't express their feelings appropriately or even through verbal communications like they used to, so they often tell us through those behaviors. And then lastly, people with dementia are unique individuals, and the strategies outlined in this webinar, we're going to be able to offer you tips and ideas to consider when trying to prevent behavioral escalation, as well as some strategies to consider if an escalation occurs. However, because people are unique, we need to really know the person behind the illness, as that will really enhance our opportunity for that successful interaction. And we really stress the importance of connecting with your teams in long-term care to really learn more about the person behind the illness and learn about what their individualized care plans are. And we recognize and we know this can be very time consuming, but it does lead to positive and rewarding outcomes, and it often takes less time in the long run. So now we do want to get you hooked up with the Mentimeter. So if you have your phone out or if you have your web browser like Mario mentioned before, we want to pick your brains a little bit and really get you thinking about some of those warning signs that you might see when you or someone you know is starting to escalate. So go to www.mentee.com and enter the code, which is shown on the slide, so 5147. And I'm just going to give you guys a couple minutes just to put in your answers there. No rush, just really think about this and what you think some of those warning signs are. All right, lots of answers are coming in. This is amazing. Okay, it looks like people are finishing up. So I'm just gonna read some of them out loud. So we have crying, pacing, yelling, silence. So you'll notice that the ones that are bolded and larger than the rest are the ones that a lot of people or more than one person has responded with. So more of a common response. So that's awesome. We have shouting, slamming doors, clenched fist, tensed, raising their voice, gritting their teeth, racial remarks. Maybe someone is nervous, impatient, having some anger. Good. You could have some trembling. Yep. Shortness of breath. Shaking the fist. Saying you smell. Yep. All those verbal commands that they might be saying. Darting glances. Yep. Restlessness and pacing. Talking to self. Throat tightens. That's a good one. Irritable, nervous. Awesome. These answers are all amazing. So just take a minute and really look at all of those answers that everybody else on this call responded with. You can see from all of your answers that there's so many different ways to recognize when you or someone you know is becoming upset and starting to escalate, right? And the fact that you guys all came up with these warning signs before we even really began our webinar really just points to the wealth of knowledge that you guys already have. And so when we're thinking about a person living with dementia, they're just like us. They're going to exhibit many of these same warning signs as well. And it is up to us to really get to know our residents and recognize these signs in order to prevent that behavioral escalation from occurring. So great job, guys. So don't put your phone away yet. We do have one more mentee poll that you will be asked to participate in. And I'm actually going to pass it on to Tara now to take us through the first key step of prevention and then move us along through the different stages leading up to escalation.
Okay, fantastic. Thank you so much, Lindsay. So let's talk a little bit about the stages of behavioral escalation. So this chart really helps us sort of make sense of those different stages. And we know that as human beings, we all sort of escalate in the same way. And this chart is a really easy way for us to understand those different stages. And it helps us also understand or come to accept rather, or identify the anxious stage of behavioral escalation as those sort of quote unquote warning signs that the resident is starting to escalate. So if we come to regard the anxious stage as those warning signs, then we'll know that it's time to stop whatever we're doing. Whatever we're doing can wait. I know that can be difficult to do at times because oftentimes we may really need to do whatever it is we're trying to do. For example, you may be trying to support a resident who may be in a soiled incontinent product, and we're worrying about skin breakdown and infections, and these are all really valid concerns. But if we're trying to help the resident change their incontinent product while they're in this anxious stage, taking the time to stop and let them calm down and recognize that they're showing us those warning signs that they're not ready to accept this care will actually save us times in the long run. Because the alternative, if we sort of just keep going, will be that behavioral escalation that we see here into the verbally responsive stage, and then the physically responsive stage, and then that outburst stage, which is really sort of your code white catastrophic stage. So we know, again, that if we stop what we're doing, by doing so, we're much more likely to prevent the escalation from occurring at all. And once the resident has entered into that verbally responsive stage, we may still have opportunities to prevent the escalation. However, what we do know is once they've reached that physically responsive stage, we are a lot less likely to prevent the escalation or that outburst stage. Something else that's important to note is really thinking about this idea of baseline. So we have to know our residents' individual baseline, and we all will have different baselines. A good example of that is, I know I once supported a resident when I worked in long-term care in my past life who at baseline would just swear. And it didn't mean they were escalating. Every other word was a swear word, and that was just sort of part of their social history and how they communicated, you know, in the community they grew up in. And if I hadn't known that, I might have misregarded that as the anxious stage. But knowing the baseline, I knew that when I saw a change from that, so maybe, you know, if the resident started tapping the chair while they were swearing, that change would indicate that they were entering into the anxious stage. So this is an example of why it's so super important to really know the individual and understand what their baseline is. And in order to do that, we need to remember that it's important to read the residence care plan, or maybe it's the Cardex, depending on the home you're redeployed to or working at, to have that baseline knowledge and communicate with the team. You know, I always say that every member of that interdisciplinary team in long-term care has such rich information about each resident that when we all bring our heads together and share, we really will have that full picture and be able to better understand that baseline and gather that knowledge. And that, of course, will really help us when we're trying to assess the warning signs, that anxious stage. Also, something to consider is using the DOS. So that's the Dementia Observation System. It's a really wonderful tool to help us establish a baseline. So if it's, you know, a new resident who may have been recently admitted and we don't have much baseline information, we can always start a DOS for 3 to 5 days, and that will give us that baseline information. So just something to keep in mind as well when we're thinking about establishing baseline. Oh, I apologize. My PowerPoint seems to be malfunctioning. There is an image that should be on the screen. I'm just going to try one thing. Bear with me, folks. My apologies. Let's try that again. All right, my sincere apologies. We are going to have to do without the image, which is unfortunate. But let's start to talk a little bit about those anxious stage behaviors. So what do we see in that anxious stage when we're starting to sort of come to accept these anxious stage behaviors as our warning signs? So we may see increased movement. And what does that look like? Possibly tapping their hands or their fingers or tapping their feet, maybe raising clenched fists, fidgeting, pacing. These are all really good indicators of that increased movement that might tell us that, hey, you know, this person is starting to enter into that anxious stage, and these are our warning signs. Let's think a little bit about facial expression. So has the look in their eyes changed? Are they frowning? Is there burrowing, or are they clenching their jaw? You can't see me, but I'm doing it right now. Thinking about their vocalization. So for example, are they swearing? Making rude comments, ridiculing, increased volume. And then thinking about verbal commands. So are they saying very clear things to us, like get out of my room, or don't touch me and leave me alone? Because, you know, it's easy, as well-meaning as we are, it can be easy to have these things go unnoticed, because again, circling back to that example of, you know, your resident who may have a soiled incontinent product, and we know that there's risk involved in not changing that. It's easy for us to ignore these warning signs because we're well-meaning and we're trying to help. But we have to remember that if we're seeing these things, and if the resident is doing any of these things or telling us quite clearly get out of their room, we will never be successful in completing that task anyways. It makes a lot more sense for us to just step back, leave, and reapproach when the person's had an opportunity to calm down. Also important to think about what we refer to as the sweet spot. So I'll use the example of pain. If you're supporting a resident who, you know, you've noticed that every time you try to help them change their shirt, whenever you touch their right arm and try to take that arm out of their sleeve, you get automatically punched. Query pain. Wonder about pain, and is that what's causing them to escalate and to punch you? And an easy way to rule that out again would be to administer some pain medication 30 to 40 minutes before care. And when you've done that and come back to provide the care, if you're not getting punched anymore, you know you found the sweet spot, and we know that, okay, let's get this into the care plan. Here's the plan for Tara. Make sure she's got that pain medication 30 to 40 minutes before care. This really understanding the sweet spot and understanding when we may need to administer PRNs during the time before the escalation increases really sets both us and the resident up for success. So I'm going to ask everyone to take out their smartphones again if you don't already have them out. And I want you to go back to www.mentee.com, please, and enter the code 522357. And we can pop that into the chat box, but again, that code is 522357. And I want us to think a little bit about that anxious stage. Now that we've talked about it, and we've talked about some of these warning signs that we see in the anxious stage that we've identified, what are some of the ways in which we can prevent the resident from escalating? So I'll give you a few moments to pop those answers into the mentee. If for some reason you don't have access to the mentee, you can always use the chat box. All right, I have a feeling technology is just not on my side. Oh, we're good. I spoke too soon. As we're entering in our responses, just to help us make sense of what we're looking at, the larger the font, the more common the response. And I love that we're seeing all of these really fantastic ideas and that the font is staying small because we've got all of these brilliant minds together in one virtual room. And this is where the magic happens, as you can see. So to the folks who are still entering, no rush, take your time. And to the folks who have already entered their responses, take a minute to have a look at the screen. And think about some of these ideas because these are all perfect. You are right on the ball with these ideas. You're exactly right. You guys are the experts, as I always say. So we'll give us all a couple more moments just to have a look at what's on our screen. So physical space seems to be one of the more common responses. I love it, you guys. This is wonderful. And as we talk a little bit about the ways in which we can prevent behavior escalation, you're going to see that these all come up. Brilliant. We'll give it a couple more moments because the screen's still moving and I want to make sure everyone's had their opportunity. Okay, amazing. Thank you all so much for participating. And as I said, these answers are perfection. These are exactly the things we're looking for when we think about how we can prevent behavioral escalation. So let's move on and do a bit of a deeper dive into some of the ways in which we can prevent behavior escalation. So personal space, let's talk a little bit about that. So thinking about our own personal space and our residents that we are supporting personal space, think about this idea of, staying a minimum of 3 feet apart Ideally, we want to provide that 3-foot space, but we know that there may be times when this may not be possible. So of course, when it is possible, it would be great. If not possible, if the care warrants us getting a bit closer, then of course that's understandable. And thinking about the grabbing and kicking zone. So if you know your resident has a tendency to, grab or kick or punch, when possible, again, allowing for that space, that personal space, to make sure that we're keeping ourselves safe as well and not getting hit. I'd like to talk a little bit about the reassurance position. So if anyone is GPA certified, who's gone through GPA, this will be familiar to you. And to folks who may not have attended GPA, not to worry, we're going to talk a little bit about it. So the reassurance position is really simple. It's thinking about turning ourselves to a 45-degree angle. So I want you to sort of envision that in your head. So the difference between me standing directly in front of you and then the difference for me turning to 45-degree angle away from you while still looking at you. Why do we do this? We're going to look smaller when we do that. We're going to appear less threatening. If I am facing you, I may be easily misconstrued as a threat, or like I'm trying to prevent you from leaving. But when we use the reassurance position, we're communicating trust immediately. We look smaller, we appear less threatening, and that exit strategy for the resident is available. So by showing them that there is a clear pathway for them to leave if they wanted to, we are again communicating that trust. Hey, I'm not here to hurt you. I don't mean any harm, and you're free to leave whenever you'd like. We have to also consider the physical layout of the space. So we want to make sure, when possible, that we're closest to the exit. So for example, making sure that we don't have our back up against the wall with no exit plan should the resident quickly escalate into that outburst stage that we talked about before. We want to assess the environment for items that can be used as a weapon. So when I say weapon, I'm thinking about things like walkers, wheelchairs, decorative figurines, furniture, maybe the resident's favorite ceramic mug that if it was whipped at her head might do some serious damage. Making sure we're aware of all of these things in the environment helps to keep us safe as well. I'll never forget my first year of practice. So this was 11 years ago, and I was working in long-term care, and I did a really bad job in this moment of assessing my environment. And I was trying to de-escalate a resident who had already escalated, not being aware of what was in the environment. And there was a Broda wheelchair. I'm not sure if everyone knows what that is, but it's a big wheelchair. There was a Broda wheelchair in the hallway because the resident who it belonged to was up and doing physiotherapy, and it was there as a safety measure just in case they needed to have a seat. And the resident who was in that sort of physically responsive, almost outburst stage, when we think about behavior escalation, quickly grabbed that Broda wheelchair and smashed it right into my legs, and I fell to the ground. And I was okay, thankfully, the resident was okay, but I'll always think of that story when I talk about behavior escalation, because I should have been more aware. I should have scanned my environment and assessed for items that can be used as a weapon. So just something really important to keep in mind. Let's think about our own interpersonal skills. So considering our mood, let's be honest with ourselves. We are all human beings here, and we all have bad days from time to time. That's just part of being human. It sort of comes with the deal. However, we need to be aware of our mood whenever we're engaging or interacting with our residents that we're supporting, because our mood can be contagious. I mean, I'm not sure about you, but if you've ever come to work and been met by a coworker who's just having a really bad day and in a really bad mood, doesn't really make you feel very good, right? You're not likely to have a good day or be in a great mood because it's infectious, it's contagious. So we need to do our best to leave our personal stresses at the door and be mindful of our leaked emotions, because they can cause that behavior escalation and we may not even realize it. We may not be aware of it. Slowing down our speech. You can't see me, but my hand is up. I am very guilty of this. If you haven't noticed, I talk fast, and it's natural for me. I have my whole life. It's something I've worked on and I will continue to work on. We need to be mindful of that. I'm very mindful of it, and I will always have to be, of how fast I'm talking. So remembering that residents living with dementia may need a little more time to process the information. Speaking at a pace that's difficult for the resident to follow may cause frustration, which can quickly lead to a behavior escalation. So just being really cognizant of the pace of our speech, not rushing the person. You know, I will be the first to admit that it often feels like we don't have enough hours in the day. And that's the reality of what we do. Sometimes we can't even find the time to use the washroom. And I'm sure some of you are laughing or nodding your heads right now. But that's not the resident's fault. And we need to be really mindful of the speed in which we expect the resident to function. So rushing the resident, even though we mean so well, may actually take more time if it causes that behavioral escalation, and may actually prevent us from completing the task altogether, than allowing them those few extra minutes to move at a pace that works for them. We also have to remember not to confront or argue. So remembering that the resident's reality is their reality. It is very real to them, the same way our reality is to us. None of us like to be confronted. I'm sure I speak for all of us. I don't like it. None of us like to be told we're wrong, and none of us like to have our deficits pointed out to us. So keeping in mind what's real to them is how they feel. And then, you know, sort of going along with some of the things that we have already spoken about, but allowing for periods of silence. So I'm sure you've noticed, if you've been to past webinars, or if you know me from other sessions, or even just from today, I'm a bit of a chatty Cathy. So for me, silence won't work for me when I'm your resident. I would love for you to talk to me and tell me all about your day and your life and your likes and your dislikes. But there are a lot of people out there who are the complete opposite of me. And for them, that would actually cause an escalation. Silence would be calming for them. And this really goes back to the idea of knowing your resident. If the resident likes to be quiet, silence will actually help them feel comfortable. And then allowing the person enough time to respond to the situation. So this also ties into a lot of what we've already spoken about. So, you know, talking slowly, not rushing the person, and allowing for those periods of silence if that's what's making that resident comfortable. We need to validate and negotiate as well. So we have to validate feelings and emotions. We know that as human beings, we all want to be understood. Validation acknowledges the emotional message behind whatever the resident is saying or doing, and really allows for that opportunity for them to be heard. So whether or not their reality corresponds, with our here and now reality, we have to remember that it's real to them. So the same way our brain is sending us the message right now that it's July 14th, 2020, you may be supporting a resident living with dementia whose brain is sending them the message that it's September 19th, 1965, and that is their reality. And no amount of reality orientation is going to help them come into our reality. We need to step into their reality. Understanding that emotional message actually also really gives us the chance to connect with the resident and step into their world rather than trying to bring them into ours, as I was saying. And that will inevitably help to avoid a behavioral escalation. We have to stay calm and paraphrase our understanding of their experience. So really, this just means repeating what the resident is saying right back to them to ensure that you understand the message they're trying to send. So for example, if the resident tells you to get out of their room, we could say something like, "It sounds like you'd like some space. How about I leave and come back later?" And you will most likely avoid that behavioral escalation by doing that. We have to try to set clear and feasible limits. So we can say things if somebody is, you know, raising their voice, for example, like, "I really want to help you solve this. I'm here to support you, but I need you to lower your voice if that's okay, so I can do that." It's okay to say things like that. And then lastly, providing choices. You would be shocked at how successful this will allow both you and the resident to be. As adults, we sort of all want to have control over our own lives. And by giving residents the choice, we're allowing them to have that control. Oftentimes, by simply providing choice, the resident is likely to be amenable to the task at hand because they have the option and are given that right to make their own decisions, which, to be honest, is really a basic human right. So saying something like, would you like me to help you transfer from bed to chair now, or should I come back later? As opposed to saying something like, hey Tara, good morning. I'm here to help you transfer from your bed to the chair. Let's do that. Both are well-meaning, both are sending or asking the same question, but the first option is giving the person the choice, and simply because we gave them that choice, I would say 90 to 95% of the time, they will say now because they've been given the option and it feels like their decision, which it really should. So again, my sincere apologies. I am having technological issues today and our images are not showing up, so please excuse the screen. But lastly, we just want to talk about if escalation does occur. So as we know, despite our best efforts, residents may still escalate from time to time. I wish I could tell you that after today's session, don't worry, for the rest of your careers, you'll never have a resident have their behavior escalate again. You're in the clear. That would just be untrue. So it's really important to talk about what we can do if the resident does escalate despite our best efforts. We need to make sure we're minimizing risk and keeping the person and everyone, including ourselves, safe. So we want to remain in the area. You want to ask coworkers if they need help. So, you may be walking by on your way to help Mr. Smith and you see your coworker trying to calm down Mrs. Jones. Don't ever assume that your coworker has it under control, even if it seems like they do. Always ask if they need help and always keep each other safe. We also want to remain in the area. So what does that mean? If we see that staff member trying to de-escalate a resident in that outburst stage, it means that we want to help and offer that support. And if they do need our support, stay in the area and offer it, but at a distance. We want to move everyone, and by everyone, I mean everyone in the area away. So when trying to de-escalate a resident, it's super important to first make sure that we have moved everyone away from the escalated person and into a safe area. I know it might be natural instinct to think we need to move the resident who's escalated, but that's actually the opposite of what we want to do. We want to move everyone else and never touch the resident who has escalated and give them their space by having them in our view, but also, again, staying at that distance. If that resident does escalate, we need to be aware that we may need to call a code white, which is that violent person code. And as such, it is so important to be aware of the code white policy at the home you're working in. Code white really pertains to any violent person. So remembering that that can be a resident, a staff member, or a visitor. We want to make sure we're always reducing distractions and noise. So we want to make sure only one person is talking at a time. If there are any TVs on or radios or music, make sure that we turn them off. And thinking about things like maybe a flickering light, again, just doing that environmental scan and doing whatever we can to really reduce distractions and noise around the person who has escalated into that outburst stage. And then last but not least, we need to consider involving authorities if it's necessary. If the resident doesn't de-escalate and is a risk to themselves or others, it may be time to consider involving external authorities to support de-escalation. So for example, it may be a Form 1 that's needed at a physician's discretion, or calling 911 if a physician isn't available. Remember that our goal is always to keep everybody, including ourselves, safe, and it's never to be a hero. Also, just something to keep in mind is that recovery period after the outburst stage. And during that recovery period, when the resident is calming down, there is still that potential for the resident to quickly re-escalate without any warning at all. So being really mindful of that and prepared will help as well. And with that, I will turn it back over to Lindsay.
All right, thank you, Tara, for taking us through those stages of behavioral escalation and providing us with some excellent strategies. So we wanted to provide you guys with some further resources that might be useful for you. So the first one there, it says RGP, so the Regional Geriatric Program of Toronto website. So all of our previous webinars are on this website, so you can go there and check them out. And then there's lots of different tips, tip sheets that are available in the resource section as well. So I definitely recommend going to the RGP website. The second one is the Alzheimer's Society Canada. So they have a really great, I think it's like under 4 minutes, a video on aggression and just some other general strategies and do's and don'ts when working with a person who is exhibiting some of these behaviors. So I definitely recommend checking that video out. And then these last two resources are different communication tip sheets. So these are really great resources to have on hand because we know that so much of our interactions and our ability to prevent or de-escalate a person who's escalating really relies on good communication. And then you'll see some of our references come up. And so we just want to thank you once again for taking the time out of your day to join us on this webinar today. We really hope that we were able to provide you with some new tools for supporting those you're working with, or maybe even validated and refreshed your knowledge on what you already know. And we would love to get your feedback on whether this was helpful and if there's other topics that you would like us to cover. So you can either type these responses into the chat box, but there'll also be a survey sent out to you, which you can fill out, and this will really help us in developing future webinars. So I'm actually going to pass it over to Mario for some Q&A.
Okay, so thank you, Tara and Lindsay, for sharing your knowledge and sharing your experiences around this topic, and really engaging the audience to find out also what their experience has been and their suggestions as to what to try. So please, if you have any questions, definitely type it into the chat box there. I see there is one question about, does the 45-degree angle not cause problems for more advanced dementia where tunnel vision is common? And somebody asked if the visual would be helpful. So, I mean, just to think about the visual, I mean, I'm going to just stand up here right now. And when we talk about 45-degree angle, you're not necessarily stepping away from the person. You're just turning slightly away. As you can see, I am much smaller, and I'm also allowing people to pass if they would like to. But by standing directly in front of them, whether they have tunnel vision or not, that can communicate a threat. So I really hope that this visual of the 45-degree angle is helping. As you can see, I'm not stepping completely away from their vision, just stepping slightly away from them. So that's also, there's another question that I got well, there is times where you have two residents. This is actually not to all entities. There's times where you have two residents that might be escalated towards each other. What do you do in those kinds of situations?
Yeah, so a really important question, and of course something that can commonly happen. I think it's important to remember that no matter what, never to try to do that on your own. So if you do have two residents that are escalating either towards each other or at the same time, either consider a code white if it is at that outburst stage phase and there is a risk to self or other, but also, consider just engaging one of your colleagues who might be able to help. And another important piece of that is really knowing your resident, as I talked about earlier, because if you are trying to de-escalate and then distract to redirect, you need to know what's meaningful to that person. So when I say meaningful, it can be something quite simple. I had a resident who really liked jazz music. So I knew that if there was ever a need to redirect that person, I could first validate their feelings, say, I understand you're upset. I'm here for you to support you. Why don't you come with me over here to the lounge and we'll listen to some jazz music and relax. And I knew it would work. But again, it's just really important to know what's meaningful to that person, because if you're trying to redirect with something that's not meaningful, you're a lot less likely to be successful. And just to reiterate, never trying to go it alone.
Tara, actually brought up a really important point about knowing your resident. You know, it seems that sometimes some residents respond better to some people rather than others. Would you say that a person who the resident seems to have a really good relationship with, that's somebody that should possibly respond if they are available in that situation to help de-escalate the situation? What are your thoughts on that?
Oh, absolutely, Mario. That's fantastic. I mean, as human beings, we're not going to connect to everybody, or we're going to have stronger connections to some than others. So if you have that knowledge that, you know, Tara responds really well to Mario because they have that great connection, that safety, that trusting relationship, and Mario's there, absolutely. Mario's the guy for the job.
We have another question here. Thinking about language that's being used to describe behaviors, what is a better way to phrase resistive or resisting care, specifically for documentation purposes?
That's a really good question, Caitlin. Thanks for asking. And I think what we need to be doing, especially when documenting, the key thing here is that you need to be really explaining what the behavior is. So exactly what you're seeing, and you know, not labeling the person. We talked a lot about labels at the beginning, so not putting those labels on the person. So not necessarily a different word, I wouldn't say, but really explaining in detail what you're actually seeing in full detail. I think that really would help with documentation, and you know, really gets down to why the behavior is happening as well. I'm not sure, Tara, if you have another word, but I kind of stay away from labeling and more so just, you know, give a really good explanation.
Yeah, absolutely. I totally agree. So if we're thinking about documentation for example, I mean, we could consider saying something like, you know, approach Tara to help her change into her pajamas. Tara was expressing that she did not want to change into her pajamas by doing such and such. So, you know, by pushing Ryder away, spitting on Ryder, asking Ryder to leave room. Ryder left to allow Tara to calm down. We'll reapproach and try again. Does that make sense?
It sounds like more specific, concrete language describing what exactly is happening rather than terms that may be perceived as vague and leaving it to interpretation of the reader of the documentation.
Yeah.
There's another question around, you know, sometimes behaviors are, oh, this is actually to all panelists. Sometimes behaviors just happen without provocation or indication. Sometimes, and we are the ones that are approaching the resident at that point. And do you have any suggestions how we can handle these kinds of situations?
I can start. So, you know, I talked a lot about this at the beginning, really trying to find the behavior behind the meaning behind the behavior, right? We really need to dig deeper and try to understand why, you know, what is going on to really have caused this person to, you know, escalate. And we don't see the person every single second of the day, right? So we really need to think about what could have happened before they got to us that might have escalated or triggered this response from them. And sometimes what is causing them to escalate doesn't really have a clear trigger, right? And I really like to use a pop can analogy to really help explain this. So just like a can of pop, we don't really know how many people before us have actually handled that can of pop. So, you know, they're shaking it, they put it back on the shelf, and then, you know, the next person, they drops it on the ground, then someone else shakes it a little bit more, and, you know, and then we go and open it, and then it explodes on us. And, you know, we're like, what? Like, I handled it so carefully, but it exploded. Like, why? And, you know, the same goes for any of us and throughout our day. Like, you know, if we wake up in the morning and, you know, we're really late for work, we're supposed to be there at 8:30, but we're getting up at 8 a.m., you know, then we get stuck in traffic on the way to work. Then the person in front of us slams their brakes and almost causes an accident. Like, all these things are happening throughout our day. And, you know, our pop can is slowly getting to the point of exploding by now, right? So we just really need to think about that. And then at some point, we're going to probably escalate. We're going to explode on someone, and it might not be someone who is interacting with us in a negative way. And, you know, people living with dementia are the exact same way. You know, small things can happen throughout the day that is really going to upset them, and they might explode. So yes, it might seem as though you didn't do anything wrong to upset them or cause them to react in that way, but we need to remember that, you know, we may just be that last straw that really broke the camel's back. So just keeping that in mind, I think, is crucial.
I guess a good way of thinking about it is that, we're not around the resident 24/7, so we don't know what exactly happened with that person before we actually entered their space, and we might be that trigger that sets them to the next stage. We have a question here. Would you offer comment on the time crunch conundrum? This is a real pressure, and many of the techniques you outline take time that is often not available. Any suggestions?
If I'm completely honest, the truthful answer to that is we need to spend the time to save the time. When we think about it, if we don't take the extra time to do these things, we're going to end up spending hours of our shift attempting to de-escalate, a code white or a resident in that outburst stage. So that's why I sort of mentioned that I get it. I totally accept that the truth is that it feels like we don't have enough time. But when we think about it that way, it sort of makes sense to try to spend those extra minutes up front to save the time and actually allow ourselves to have more time to get everything done, if that makes sense. Mario, did you have anything you want to add?
I also think about like incident reports that need to be done afterwards, and thinking about the documentation following a code white and still not getting the task done. I would say that, that if you add up all those minutes, it actually will take more time if we take those couple of minutes to connect with the person first. So I definitely agree with you there, Tara.
Great questions, though, I have to say.
Good questions. So I think at this point, we're going to end the webinar. So the SurveyMonkey link for your feedback, we welcome all your